Dylan, how does this advance?
Now try again.
Oh, well, I'm on this one. Oh, there we go. Okay. And of course, no relevant financial disclosures for this talk. So in this talk, we want to learn how to quickly and accurately identify concussive injury, understand the new guidelines and sideline management tools that we have at our disposal to sort of identify concussions and get these athletes back to play safely and also in a timely manner. We want to understand on-field and in-office management in the acute, subacute, and the chronic time period. We want to identify any factors that might contribute to prolonged symptoms. We'll briefly discuss the roles of medications and supplements, and we'll review areas of current and future research. So concussions are incredibly prevalent. It's estimated that 1.6 to 3.8 million sports-related and recreation-related traumatic brain injuries, which include concussions, occur each year in the United States. This is likely an underestimate of the actual number of concussions yearly because it depends on reporting, and there's probably a large subset of concussions that happen certainly in the recreational kind of sphere that aren't being reported. So this relies on reports from a coaching staff or your athletic trainers. And we know based on some cohort and population-based studies, when athletes are surveyed and asked about, symptoms suggestive of a concussion and then asked if they report it or if they don't report it, there's a significant majority of athletes that actually don't report these symptoms to their coaching staff. And so in studies, anywhere between 30 and 50% of athletes won't report it. So it really is dependent on us as physicians to go out there and recognize this when we're on the sidelines, and on our coaching staff to recognize it and be able to pull those athletes out. It also doesn't include any work-related or motor vehicle accident-related concussions. For those of you who do workman's comp, that's also something to sort of think about. We know that since we've been studying concussions, the rates have steadily increased both in high school and collegiate athletes. This is probably both due to increased reporting and also increased incidence, just as the number of athletes actually participating in sports has increased. Concussions have a significant impact on athletics and academics. And the other thing I want to highlight in this speech is that as sports medicine physicians, or just physicians in general, our number one goal is to return these athletes to their academics or to their work kind of where they were before, their academic baseline or their work baseline. For us athletics, even though we are sports medicine physicians, that's secondary. These kids need to be successful at work and school first before they can be successful in sports. And so we really want to highlight that. And depending on the recovery rate of concussions, for some of our athletes, this can be 2 or 3 weeks of missed school, which is not insignificant. So we'll go over later in the talk how to deal with that. When we talk about which sports confer the highest risk, we see the highest rates of concussions in American football and soccer. Interestingly enough, sort of European football, which is rugby, carries much lower rates of concussions, and that probably has something to do with the fact, that they don't have all of that protection, so they don't think that their head is like just another sort of blocking agent to use. We also know that 90% of head injuries seen in the ER are actually concussions, so those of you who are emergency medicine physicians will also be seeing a lot of these. And then again, just looking at the incidence in sports and the rates per 1,000 games, you can see for males, football is quite a bit higher at 3.02% per 1,000 games here. And then for females, soccer at 1.8. So just going through definitions, concussion is considered a clinical syndrome characterized by immediate and transient impairment of brain function caused by a traumatic injury that resolves spontaneously. The injury may be direct, so like head-to-head, or indirect, so sort of a force transmitted through the body that results in enough force to cause a concussion. And it results in a functional or metabolic disturbance, not a structural injury. You do not have to have a loss of consciousness, and loss of consciousness does not necessarily convey severity of injury. We know that the majority of these concussions will resolve in a short time period, and it will follow a generally understandable and sequential course. And there are no abnormalities seen on imaging. So just briefly talking about that neurometabolic condition in the biochemistry, immediately after the brain sustains that force that results in a concussion, the way that we explain it to our parents and our families is that it's almost as if it stuns the brain and prevents the brain from auto-regulating. Very briefly, what ends up happening is that then You get an immediate decrease in blood flow, up to 20% on these studies, and all of your pumps that are keeping certain ions inside the brain and then certain ions outside of those brain cells end up getting dysregulated just for a second. And so potassium and calcium end up effluxing out of those neurons. This then triggers the sodium-potassium pump to sort of kick into overdrive once it recovers, trying to get potassium back into the cells and restoring that potassium homeostasis. That requires ATP and energy. So you have this combination of increased cerebral energy requirements and decreased cerebral blood flow. That results in lactic acid formation in the brain that then has to be pumped out, and explains a lot of the symptoms that we see in our athletes with regards to, headaches and photophobia and some of these other things. This autonomic regulation can be disrupted for several weeks, and then that's this vulnerable window where the brain is more sensitive to an additional injury that we really have to watch out for, that we'll discuss later. This just reviews that neurometabolic cascade, so you can see in the minutes after a concussive injury, you get this quick efflux out of potassium that then the sodium-potassium pumps kind of kick into overdrive to try to get potassium back into the cells. That results in this lactic acid formation, and also some glutamate comes out of the cells, and the glutamate is directly irritating to the neurons as well. Calcium effluxes out, but this takes longer to get back in, and you can see down here on this timeline, in certain studies, up to a week to get calcium back to normal, and then cerebral blood flow is decreased for up to 10 days after injury based on our sort of basic science studies. When we talk about the mechanism of injury, it can be a linear acceleration. Oftentimes it's this angular or rotational acceleration measured by G-forces, and so that combination, what can be so challenging with concussions, and they've tried to do these angular rotation studies where they've put accelerometers and like G-force measurements on high school kids, their helmets when they've gone out and played sports. Each individual has a different concussive threshold. So some individuals can sustain pretty heavy hits and not kind of go over that threshold and develop concussive symptoms, whereas other athletes can sustain what we would consider to be a relatively minor hit and develop these same concussive symptoms. So we gather all of this information, and unfortunately, unless we're going to put accelerometers on every kid and sort of have them go out there and hit as hard as they can until they develop a concussion, and then say, okay, that's your threshold, which obviously we're not going to do. It's tough to actually translate those forces, the numbers that we're coming up with, into some sort of a criteria or a data to be able to say, if we keep hits underneath this threshold, concussions won't happen. But when it does give us some information just with that linear acceleration, that angular and rotational acceleration, and this forceful blow that results in a rapid movement of the head, and so the classic coup contra coup, resulting in a concussive injury. When we talk about the official definitions, there's been the International Conference for Concussion in Sports that's been meeting since the early 2000s, and they provide the definitions and also the guidelines for us for concussion management. The most recent definitions were revised in 2016 in Berlin. Previously they were in Zurich, so you might have heard reference to the Zurich guidelines in the past. But our most recent guidelines are from Berlin. So a concussion, based on these 2016 consensus guidelines, a concussion is a traumatic brain injury induced by biomechanical forces, like we said. It may be caused by direct blow to the head, face, neck, or elsewhere to the body with that impulsive force transmitted up to the head. It typically results in that rapid onset of neurologic impairment, and this is immediate. And if any of you have ever provided sideline coverage, you know when that kid goes down and sort of stays down, that's the kid that you want to come off the sidelines immediately so that you can do that evaluation. Oftentimes, like I said, the neurologic impairment should be transient and it should resolve spontaneously. Very occasionally, you'll see some symptoms evolve over minutes to hours. Acute signs and symptoms are the result of functional disturbances, like we said, and so any sort of standard neuroimaging that we have available in the emergency room or even in your office afterwards is going to be normal, and that's kind of the hallmark of these concussive injuries. It may or may not result in the loss of consciousness, like we said, and it results in a graded set of clinical symptoms with resolution following a sequential course. Occasionally, symptoms can be prolonged. So here are some classic examples of concussions. As you can see here, head to head. And so what I want to point out here, actually, just kind of deviating a little bit, is there's been a lot of controversy very recently about heading the ball in soccer and what's the appropriate age under which kids should not be allowed to head balls. And so some recent sort of consensus guidelines have come out of the AAP that potentially maybe kids shouldn't be heading balls under the age of 11. This is not from the ball hitting, the concussions that you're seeing, that we see, are not from heads hitting balls. They're from heads hitting heads, right? And so this has more to do with improper coaching and training techniques than it does about the actual ball hitting the head. If you have youth athletes that are properly trained to head the ball, then they should be allowed to do that if they're using an appropriate size ball for their age, because remember that soccer balls are actually graded to age, and that they've been taught how to head correctly. So look, both eyes are closed, nobody's looking at where the ball is. This is just a setup for a disaster. So this is kind of retraining. And that really, a lot of concussions we'll talk about. The best thing that we can do to prevent them is to actually train our athletes how to play their sport correctly. Here too, helmet to helmet, helmet to chest. And look at this, he's not even leading up. So this is a tackling issue here. So when we talk just briefly about legal issues, unfortunately, so currently 48 states and Washington, D.C. have specific youth concussion legislation. All states have some form of concussion legislation, but Arkansas and Wyoming don't have anything real significant at this point. So those of you from Arkansas and Wyoming, if you want to go back and legislate, feel free to do so. In Florida, our laws were enacted in April 2012. We require now that there must be parental consent and acceptance of concussion risks, so that's part of their pre-participation physical that they kind of sign off on if they're going to be participating in Florida high school athletics. We require immediate removal from activity if a concussion is suspected. There is no such thing as same-day return to play. So some of you, if you remember, I mean, there used to be sort of concussions like 1, 2, 3, and then mild, moderate, severe. We don't have that sort of a grading system anymore. A concussion is a concussion is a concussion. So if it happens, it doesn't matter. They can't go back. And then we also require return to play after written medical clearance by an MD or a DO. And this all stems from what's called the Zachary Lystead Law. And this was a young man who played youth football in Washington State outside of Seattle, I believe. He was 13 at the time. And he was a star athlete. He played on their defensive and their offensive teams. So in the first half of the game, I think there were like 3.5 minutes to play, he went in for a play, took a hard hit, went down, and was actually rolling around on the field for a few seconds holding onto his head. So again, that is somebody that Dr. Rodriguez or myself would immediately pull off the field for evaluation. But he kind of got back up, and they held him out for the last 3 minutes of the play, and they sort of evaluated him on the sideline and said, "Are you okay to go back in, Zach?" He said, "Yeah, I'm okay to go back in." Goes back in, the second half sustains another hit, now has permanent neurologic damage, still alive, thankfully. But because he returned to play prematurely, sustained a second fairly minor hit that resulted in permanent neurologic deficits, which for a 13-year-old is just devastating. And so in Washington State, they enacted that law soon afterwards. The injury happened in 2006, so they enacted the law 3 years later, and it served as a model for most other states. And again, all of these laws require guidelines and education, mandatory consent from parents and athletes, immediate removal, written clearance before return to play. And for us as practicing physicians who might be dealing with this, legal immunity if we're compliant with the law. So as long as we follow those guidelines. So, bringing you back onto the field, our first step is to sort of recognize these concussive injuries. Any player that is involved in a play resulting head-to-head, head-to-ground, or head-to-equipment should be carefully monitored by you as a sideline physician for any signs of concussion. So again, if they're slow to get up, if they look confused, if they're not going the right direction after a play, the bulk of the athletes move one way and your athlete's moving the other direction, they need to come off. If they're spending more time down on the ground than you want to, just bring them off. If you do bring them off, certain signs and symptoms of an acute concussion that they might report are headache, feeling like they're in a fog, or a deer in the headlights look, that sort of stunned look that you see. They might have increased emotional lability, so they're really tearful, which seems kind of odd after you bring them off. That's something that we see a lot. They really want to go back on, and they'll start crying. I mean, you'll see these high school football players start crying because they want to go back on, and it has nothing to do with the game. That's a sign that they should sit out. Any players experiencing a loss of consciousness, I mean, this is sort of obvious, or amnesia, so they can't remember details about the events leading up to the collision or the recent plays. Delayed reaction time, like we said, and any balance deficits. If they look like they're stumbling, then again, bring them off the field and evaluate them. Any player exhibiting features of a concussion should be removed from play immediately for sideline evaluation. And we have several standard sideline assessment tools that we can use that have been validated in both children and adults to sort of guide our decision making. These players should be evaluated by a physician or a healthcare provider, and you should also evaluate for any associated cervical spine injury, as these can occur concurrently, or they might be masking certain symptoms of a concussion. If there's not a qualified provider on site, then they should be removed from play as soon as possible and shipped somewhere as soon as possible for evaluation. And again, no same-day return to play. So this is going to be on the slides over and over and over again. So if you don't remember anything else from this lecture, do not let them go back if you suspect a concussion. In terms of sideline management, we want to make sure that we're assessing the A, B's, and C's, and there's not some other life-threatening reason that they're stumbling off the field. Rule out any confounding injuries like a cervical spine, skull fractures, or bleeds. Assess for their symptoms, perform a cognitive evaluation and a balance assessment. You will want to perform a focused neurologic exam, and the reason for that is not that there are associated neurologic defects, but if you find a cranial nerve injury, or you find some signs that are suggestive of a cervical spine injury, then that points you in a different direction. So you need to rule those out because those are also emergent things. And then we can perform sideline neuropsychological testing like the SCAT-5. That's the most recently updated neurocognitive testing that we have, both for rapid screening and to say, yes, this does appear to be consistent with a concussion, and also to establish a post-injury baseline for the patient, that you'll be able to sort of, when you're seeing them back in the office, perform these serial exams to see that they've improved from that baseline. This will take about 10-15 minutes, so not a huge portion of time. So the SCAT-5, it's a validated concussion assessment tool used for evaluating concussions in athletes aged 13 and older. For athletes aged 12 and younger, there's the child SCAT-5. These are available for free online. So you can print it out. You can have a bunch of copies that you keep with you when you're performing these sideline evaluations. You can laminate one and then just kind of write on it with marker and erase it if that's the way that you want to do things, whatever you want. And you can use it, like I said, on the sidelines and in the office for those serial exams. It also includes a modified Maddox, which many of us remember, questions about, which play were you just in, where are we playing, what's the score. Here's an example of what the SCAT-5 looks like. The nice thing about it is that it gives you some red flags just in case you forgot everything again that we were talking about today. Or if you forgot your medical training and for some reason, things that we all remember as being red flags. So it highlights those for you, and then it'll give you those modified Maddox down here. The other nice thing is the symptom evaluation. This you can just go through quickly and kind of score their symptoms. And this is very useful for grading, kind of evaluating their return as they move forward. Here is your cognitive screening. Sorry, I keep pointing this at you, Dylan. Here's their cognitive screening here. So you'll ask them for immediate and delayed memory recalls, and then a balance exam, and then your neurological screen. So this is the sideline balance assessment that we do. It's called the BEST scoring. You'll have the athletes, you don't need a box, obviously. You just have them stand on the sidelines. Make sure that nothing is taped. Their shoes are the way that they should be, so there aren't other confounding things that are throwing off their balance. But have them stand first on just a hard surface, so again, the sideline, or if you step behind the football field onto the track, that's usually a good way to do it. So their hands will be on their hips. First, you want them to stand just for 20 seconds, feet side by side. And then you're going to have them stand a single leg non-dominant, so most of them, sometimes they won't remember, so if you just ask them what foot they'll kick a ball with, then you just pick the other one. That's an easy way to do that. And then you'll have them do a tandem stance. If they have balance checks, so what you'll see is, especially in an acutely concussed individual, they won't even be able to do this. So they'll try to stand side by side, eyes closed, and they'll be wobbling like this. And so that's an athlete. If they step outside, if they wobble, and they're making multiple breaks in balance, then that's an athlete that has a problem with their vestibular system who shouldn't be allowed to go back to play. If that all looks okay, the next step is to go ahead and do it on, here you see a foam mat, but any sort of soft surface so that their ankle, muscles are being a little bit more challenged. All right. So if you're seeing these athletes not on the sideline, but you are an emergency room physician and you want to go ahead and evaluate these athletes in the emergency room, many of the sort of standards that we talked about before are the same. So you want to perform a comprehensive exam, including the history of the injury, a neurologic exam, mental status testing, gait testing. Perform your neuropsychological testing like we talked about. Evaluate for any signs of improvement or deterioration, because there are obviously going to be minutes to hours outside of that injury. So if they're rapidly kind of declining in terms of their mental status, things like that, then again, you'd be thinking of an alternative diagnosis. Concussions should not be rapidly deteriorating. And then you will evaluate based on that history and physical the need for further evaluation and emergent imaging. So these are our red flags: a focal neurologic deficit, neck pain or tenderness, vision deficits or double vision, numbness or paresthesias in the arms or legs, a severe or worsening headache, seizures, loss of consciousness, decreasing level of consciousness, vomiting, increased restlessness, agitation, or combativeness. All of these suggest either a cervical spine injury or a head bleed or a fracture, and they should be evaluated with further imaging. Just briefly, if we want to touch on, there are several subtypes of concussions. And so you can have a cognitive or fatigue type concussion that's usually treated with mental rest, medication, aerobic exercise, and neuropsychological evaluation. Cervical concussion, which is addressed by rehabilitation and strengthening of the cervical neck muscles. Vestibular concussion, which is a balance deficit that tends to be prolonged, and so that's treated with vestibular rehab and aerobic exercise. Oculomotor concussions, and so that's usually eye evaluation. There's specific oculomotor rehabilitation that we do. Post-traumatic migraines, that's usually managed by medications and neurology, or mood disorders, and that's neuropsych or medications. And then, you know, we've identified these 6 subtypes, but many athletes will have, they'll have factors of multiple subtypes, and so treatment is really multimodal. Going back to the emergency room, in terms of indications for imaging, any red flags should suggest an alternative diagnosis and should trigger further investigation. Concussions should not be presenting with those red flag symptoms. Again, conventional imaging will not diagnose a concussion. You're doing conventional imaging because you want to rule out one of these other red flag symptoms. We recommend a head CT or an MRI if you're suspicious of a skull fracture and intracerebral pathology, so like a subdural and epidural hematoma that you would need to rule out. We would recommend considering neck imaging for neurological symptoms or any sort of paresthesias, just to rule out a cervical spine injury. If you're seeing these athletes in the office, let's say, you know, you're just a regular run-of-the-mill sports medicine physician, or like Dr. Rodriguez or myself, you have Monday morning clinic after football, so they've had a few days, they've been diagnosed with a concussion. You know, if you're a sideline physician and you don't feel comfortable managing concussions, you should refer them to somebody who does. Or if you're just a regular primary care physician and you don't feel comfortable managing concussions, refer them to somebody with knowledge regarding concussive management within 24 to 48 hours if possible, so that they can be managed appropriately. We recommend physical and cognitive rest following injury until in-office evaluation. We used to say, and I'm sure we all remember, telling athletes to basically kind of sit in a dark place until you feel better. And we know, especially for adolescents, that that's challenging, and then they sort of perseverate on how badly they are feeling. And so we recommend some gentle exercise, like 48 hours after the onset of symptoms, just to kind of get them outside and help them to feel a little bit better. We do recommend complete cessation of electronic devices and schoolwork. That's the hardest thing, not the schoolwork, but the electronic devices is the hardest thing to get our athletes to let go. But we know that that requires such huge demands from our oculomotor system and also from our cerebral metabolism that we want them to not make those increased demands until they're feeling better. In the office, we recommend serial physical exams, including a complete neurologic exam every time you see them, again, just to continue to confirm that this is indeed a concussion and not something else. We also recommend the repeat SCAT5 testing. It's most important the first 3 to 5 days after concussion, and then the utility wanes, with the exception of the symptom checklist. So again, that's a nice thing to have and sort of follow serially with your athletes, just to see how their symptoms are evolving and hopefully resolving. The best balance testing is something that we do continue to do in the office, and so that was what I had showed you previously, and that identifies any acute postural stability defects. Generally, it's present the first 72 hours post-concussion in patients who continue to have vestibular defects that'll continue to be present, and that's something, if they're continuing to have defects there in a week or 2 weeks out, you're suspicious that this might be a more prolonged course. On our physical exam, we're going to do balance testing, so the Romberg, BEST testing, postural instability testing, tandem gait, tandem stance, our cranial nerves testing, pupil testing to make sure that you haven't missed something crazy, of course, and then extraocular movements. Check your tendon reflexes, check your cerebellar testing, mental status testing, motor and sensory testing, and oculomotor testing. So that's something specific that we do with concussion management, which is rapid alternating eye movements and convergence. We know that this is oftentimes very delayed and will result in some significant saccades both vertically and horizontally with our rapid alternating eye movements, especially immediately after a concussion. That's another thing that we can sort of monitor throughout the physical exam as they're improving. What's amazing with convergence is that patients will initially have symptoms when the finger is way out here. They'll start seeing, it'll start to become blurry and they'll start to have headaches. And then as they resolve, as the concussion resolves and those neurometabolic changes kind of go back to their homeostasis, their convergence becomes much more in line with what you would expect for their age and gender. And so that's a very useful, very simple test that we can do in the office. The other cornerstone of management, at least for us as sports medicine specialists, is neuropsychological testing. It can be paper or pencil, or it can be computerized. I'll tell you that we all do computerized at this point. It's just easier for us, and it offers a little bit more objectivity for us. It's an objective assessment of several domains of function, including verbal and visual memory, processing speed, attention span, working memory, sustained and selective attention time, response variability, problem solving, and reaction time. There are several different kinds of computerized testing. Almost everyone uses, at least around here, almost everyone uses the impact testing. HeadMinder is specifically used by the military, so those of you that work with the military will see those sorts of testing. But we use impact here. The NFL, the NBA, the NHL, all of your professional sports leagues use impact testing. And I'd say that's what the majority of school districts around the nation use. So, neuropsychological testing is most helpful in evaluating symptoms when it's conducted serially and when a preseason baseline is conducted. So it's tough when you don't have a preseason baseline and you're doing it with these athletes because you don't know what you're trying to get them back to, and you don't know how far they've deviated from the norm. It provides us important clinical information regarding concussion resolution. So we know that cognitive functional deficits may lag behind symptom resolution, and with an athlete who's motivated to go back, they may say that they feel just fine, and we can do all of our testing, and our testing seems just fine, but then we go ahead and we do this neuropsychological testing, and we see that there are still significant delays from their delays in their reactive motor times and things like that. That tells us that they're still recovering, and so that's a useful piece of information for us to continue to hold them out from play. It should not be the sole basis for return to decision making. You want to use that with your physical exam and what they're reporting to you. And again, we can sort of use it to determine safety for return to contact sports. With regards to pitfalls to neuropsychological testing, not all patients will have a pre-injury baseline. And so again, it's tough to say if they've come back to their baseline if you don't have one. All of these tests will give you a percent of predicted. So they all have sort of norms that you'll see where an athlete should be sort of performing based on age and gender and those sorts of things. But yeah, obviously everyone's an individual, and you can't tell for sure that that would be their baseline or should be their baseline. It can also be difficult to assess effort. There's been anecdotal evidence, and I think actually Peyton Manning is probably the most famous example of this anecdotal evidence of gaming the system. And so there will be athletes who will choose to, when they're given these tests in the preseason, they'll choose to actually fail it. And that way, their thinking is they'll go ahead, they'll fail it, they'll give a disastrous response to this test, and then if they sustain a concussion, they don't have so far to kind of get back to be considered at their baseline. The other thing that I will point out is that many of your athletes will have already sustained a concussion in previous seasons, and although we assume that they should be back to kind of what their baseline is, some athletes will continue to have some cognitive issues, especially if they've sustained multiple concussions. So, ideally we want to be administering this test to athletes who've never ever had a concussion, so that way you can kind of grade their response, and that's just not possible with the way that we've implemented it. It also might not be as accurate in patients with learning disabilities, especially ADD, because a big portion of this test is monitoring reaction time and attention, and obviously that can be challenging in athletes with a learning disability. We also know that group-administered testing environments tends to result in lower test scores. So, classically, at least here in Pinellas County, all of the athletes they get all the football players together in the gym and they just give the test to them. So you can imagine what our test responses look like. Ideally, these should be administered individually. In the first 48 hours after concussion, like I said, we recommend physical and cognitive rest. You can do repeat assessments to make sure there are not declines or changes in mental status, but the old adage of waking them up every 2 hours immediately, so the kid gets a hit and the sports medicine doctor tells the parents, make sure you're waking them up throughout the night every 2 hours, make sure they're feeling okay. You don't need to do that. Let them sleep, let them have a good night's sleep. But you should be sort of checking in, so when you bring them home, how are you feeling before you go to bed? How are you feeling the next morning? How are you feeling? Symptom management as needed, so usually that's addressing the headaches that they're complaining of. You can try some NSAIDs and some Tylenol. We don't recommend scheduled dosing, and I'll get into why we don't recommend just scheduled dosing of NSAIDs and Tylenol later, but you can give them that medication as needed, and then obviously you avoid any activities that aggravate them. So especially for kids, it's going to be the phones, it's going to be the computers, it's going to be television, it's going to be video games. All of those things increase their sort of metabolic demands in the brain and should be avoided until they're feeling well, because we really want the brain to just recover on reestablishing that homeostasis. Reading is also stressful for the brain, and so again, no schoolwork while they're feeling symptomatic. In the first 7 to 14 days following a concussion, most patients should have resolution of symptoms spontaneously without any additional intervention. So if you just let the brain rest, for most patients, anywhere between 85 and 90%, they should just get better, which is nice. We don't really have to do anything. And like I said, after the first 48 hours, we now recommend some gradual exercise. And this is not going out and running. This is going outside for a walk around the block, or, that's basically it. Anything that involves balance or coordination until that's back to baseline shouldn't be done. And as they feel better, they can kind of increase their aerobic activity a little bit as long as they stay below that symptom threshold. As I said, there will be 85 to 90% should recover in 10 to 14 days. There will be a subset, 10 to 15%, which is not insignificant in truth, who will report persistent symptoms. So in adults, that time frame is 10 to 14 days. In children, it's actually 4 weeks. So we give children longer to recover and get back to baseline. In those athletes who have prolonged or persistent symptoms, that's where we talk about multidisciplinary therapy, working with a neuropsychologist, working with a rehabilitation specialist to sort of address what their persistent symptoms are and be able to treat those appropriately. So we use vestibular rehabilitation to address balance deficits, individualized symptom-limited aerobic exercise, and neuropsychology evaluation and treatment for any persistent mood or behavioral issues. Generally speaking, these athletes who are reporting prolonged or persistent symptoms, they'll have this collection of sort of non-specific post-traumatic symptoms like headaches, anxiety. A lot of them are mood-related, anxiety, depression, sleep disorders. What can be so challenging for us as practitioners is that it's tough to say if this is all the consequence of the concussion or if it's associated with some pre-morbid conditions which are sort of manifesting or which make it more difficult for them to sort of have that cognitive resilience or that cerebral resilience and bounce back from this traumatic event. Return to school, that's incredibly important. Like I said, that's our number one priority. It's truthfully not return to athletics, it's return to school. So here in Pinellas County and also in Hillsborough County, we have guidelines that we've created. Well, I say we, this was back in my time when I was at All Children's, and so now I'm not a fellow anymore and I can't say that. But Dr. Rodriguez, my partner here, has worked closely with the school district at All Children's to create a standardized return to academics, just like a return to play protocol that the school board has recognized. And so if we make those recommendations for accommodations, they must be followed, which is really helpful for us as physicians to make sure that these kids are not overstressed when they do go back to school. Our general rule of thumb is that patients should be symptom-free for 24 hours before attempting to return to school. Occasionally, when we're dealing with kids who have been out of school for 6-8 weeks, we might try to get them back to some semblance of school with some minimal symptoms, and then we're sort of working with them individually. But in general, you want your athletes to be symptom-free. And so if you're seeing them on Monday morning and they said, I had the hit on Friday night when I was playing football, Saturday I didn't feel so hot, but yesterday I really felt good, and mom is like, yeah, he was on the phone all day yesterday, he slept normally, he's fine, then that Monday morning you kind of clear them to go back to school. Initially, we recommend a trial of half day, and we have all sorts of accommodations. So in general, we'll say go back to school half day. We say no screen time, no testing at that time. They have access to a quiet place during lunch in any study halls. They're excluded from any extracurriculars in any gym class or music class. As they continue to improve, then we'll remove those restrictions. Once they've done a half day successfully with no symptoms, then we'll bump them up to a full day. Once they've done a full day successfully, then we can bump them up to maybe some limited screen time, maybe doing testing but with extra time allotted. We also have 50% of homework and missed days. They always have access to a counselor to work on an individualized kind of return to normal so that they're not just falling behind in schoolwork. The advancement is based on their symptoms. So if they're feeling well and they advance through this without any increase in symptoms, then fine, great, they can continue to do so. If they start to develop symptoms, then we back them down. Very, very, very occasionally, we'll have some athletes that end up getting transitioned to sort of that hospital home care where they're doing the individualized schooling at home. That's maybe 1 or 2 athletes, like a semester. We really try not to take them out of school if we can help it. Once a patient's been back at school, 24 hours with no accommodations, so they're totally normal in school, then we can go ahead and start returning them to play. And so we have a stepwise graded exercise program. It consists of 5 stages, each stage lasting 24 hours, and at least here in the state of Florida, the athletic trainer signs off that they've completed each stage successfully. So the kid brings this to the athletic trainer and they're doing it individually with the trainer. Once the patient's successfully completed all 5 stages, they're reevaluated by a physician who then signs off, and that's the clearance to return to play. Interestingly enough, if you think about it, they're symptom-free on Monday, they complete those 5 stages, and they can magically play football again on Friday. So, the joke is like, where did those numbers come from? And I guess it came from our high school coaches. But, I don't know. So most athletes will progress through this successfully. Occasionally, if an athlete has difficulty at a stage, then you back them down to the previous stage until they can do that symptom-free. This is the example of the Florida High School Athletic Post-concussive Injury Form, so it's called the AT-18. You can also find this online if you don't have it, if you're seeing those athletes in your office. And so this is where, so initially they'll fill out this, they'll come to see you immediately afterwards. You'll say, yes, you're symptom-free, you can go ahead and start this return to play protocol. And here's a graded return to play. So the stage 1 is sort of just very light aerobic exercise that shouldn't induce any symptoms. Stage 2 is a little bit heavier aerobic exercise. Stage 3 with some sport-specific drills. Stage 3 is non-contact. Stage 4 or day 4 is regular practice, and then 5 they're good to go. And if they complete that successfully, the athletic trainer will complete this part, and then you'll complete on page 2 that they're okay to return to play. And all of that must be completed before they legally can go back onto the field. In that subset of patients with prolonged recovery, we know that there are certain factors that can contribute to prolonged recovery. So in that 10 to 15% that we're talking about that are going to have symptoms greater than 14 days for adults and greater than 4 weeks for children, there are certain pre-injury factors that can contribute to prolonged recovery. These include a history of previous sports-related concussions. So if you've sustained a concussion in the past, it increases your risk for future concussions. It also increases your risk of prolonged recovery, so athletes who have had multiple concussions in the past. And it also increases your risk of sustaining a concussion at sort of a lower impact or a lower velocity, so it doesn't take as much force to induce that same concussive effect. Other sort of personal risk factors include a history in the athlete of any mental health problems, especially depression and anxiety, a history of migraine headaches, and also female gender in some studies. Post-injury factors that contribute to prolonged recovery include initial severity of cognitive defects. So a patient who's sort of checking off everything on your symptom checklist is probably going to have a more prolonged recovery. The development of post-traumatic headaches or migraines, so these are patients who have persistent headaches or migraines consistently every day after the concussive injury. Reported dizziness, this is actually an incredibly strong predictive factor. So athletes who initially report dizziness on that symptom checklist, you really have to have your feelers out and keep a close eye on, because these are athletes who are going to continue to report symptoms for several days afterwards. And that probably has to do with the impact of the vestibular system and the oculomotor system. So these are athletes that maybe in the office we might consider referring to vestibular rehab or oculomotor rehab a little bit sooner to try to address that head on. Athletes who have difficulties with oculomotor functioning, and any athletes who are reporting symptoms of depression also tend to have more of a prolonged or protracted recovery course. I will talk briefly about pharmacology. There's limited evidence to support use of any sorts of medications. And again, like I said, 85 to 90% of athletes will recover with nothing more than rest and an elimination of kind of electronics. And so medications are really reserved for those athletes in children at the 4-week mark who've not improved, or in adults at the sort of 2-week mark. There's not been any evidence to show increased recovery times. So we consider medications if the symptoms have exceeded that typical recovery time, and if the negative impact of the symptoms outweighs the risk of medications. And if you, as a clinician, feel knowledgeable and comfortable in managing a sports-related concussion. So there are a couple of domains that tend to be more problematic for these post-concussive athletes who are suffering from post-concussion symptoms. Sleep is one of the main ones. So first we want to address sleep hygiene. That's kind of like with everything in life, right? You want to do the simplest, low-budget thing first. We recommend avoiding caffeine, alcohol, and which in your child athletes shouldn't be an issue for you, right? We hope. And daytime naps. So some naps are okay, but if they're napping like 2 or 3 hours during the day, then you want to try to get them to get that sleep at night instead. Melatonin is safe and non-toxic and appears to promote sleep, so that's often our first line choice, is to recommend some melatonin. You'll notice I'm not giving you doses, and there's a couple of reasons for that. A, because nothing's been FDA approved for that. B, because oftentimes we're dealing with children, and so that dose is kind of weight dependent. But melatonin is one option, and that's usually what both Dr. Rodriguez and myself start with, because that's easy to do. It does appear to promote sleep. You just have to make sure that they take it far enough before, so like an hour or two before sleep. It's not something that you can take and then fall asleep 15 minutes later. Trazodone is something that's used pretty widely in the traumatic brain injury, so any of my PM&R colleagues will probably use trazodone quite a bit to help promote sleep. Those who are dealing with those traumatic brain injuries more. It's less common used in sports-related concussions, but might be considered. Tricyclic antidepressants is another one, and this is, again, where you really have to be cautious. So if you're going to prescribe a tricyclic antidepressant to a kid, you should feel comfortable with the dosing, and you should feel comfortable managing these, because we know that this has sort of a narrower therapeutic index. It can help with sleep and also with headache and depressive symptoms. So again, looking at the other symptoms that they're complaining of and seeing if that's a medication that might work well for multiple domains. We do recommend that you avoid benzos. I mean, again, if you're dealing with a kid, you're hopefully not prescribing them Ambien or Lunesta. Those are not things that you should be giving them anyway, but it doesn't appear to help with post-concussive sleep disturbances. So we recommend avoiding those for a variety of reasons. Patients who are complaining of somatic symptoms like a headache, like I said initially or previously, we want to avoid scheduled NSAID use as that can result in rebound headaches. So as soon as they stop taking the anti-inflammatories, many patients will report this increased severity of headaches. So that's why we tell them to only take it as needed and not scheduled. Amitriptyline, again, can be considered. There are other conventional headache treatments that you can try, like beta blockers, calcium channel blockers, any of your anticonvulsants, but I don't really recommend that just because you get into some side effects and some challenges with pediatric dosing. And again, our ultimate goal is actually to kind of address the disturbance that's going on and eliminate the headaches that way as opposed to just medicating them. Emotional deficit, so depression, anxiety. This is oftentimes where your neuropsychologist can come in and be very helpful to help these athletes deal with these symptoms. It's this feeling of feeling overwhelmed and sort of scatterbrained, and so that's where the neuropsychologist can sit down and help them come up with coping mechanisms that can help to address the anxiety and depression. Tricyclic antidepressants and SSRIs have been used, and sertraline specifically appears to offer symptom improvement and cognition improvement, but that's something to sort of work with the neuropsychologist and decide. And remember that none of these are FDA approved for this specific indication. When we talk about cognitive deficits, so these athletes that appear to have persistently delayed reaction times and who are feeling persistently in a fog, there are a couple of medications that we can consider. Methylphenidate, which we use classically for ADD, can be used. It appears to help athletes both with speed of processing as well as deficiencies in general cognitive functioning. Any athletes with a convulsive disorder, you should be cautious of use of methylphenidate as seizure threshold is lowered, and those athletes are probably not participating in contact sports if they have a seizure disorder. Amantadine is another thing to consider, which can improve executive function and cognition, and that's generally safe in all ages, so that might be a better first-line agent for us. With regards to supplement use, there's no evidence to support supplement use at this time. Certain supplements have been suggested anecdotally, like magnesium and riboflavin, which is your B vitamins for post-concussive headaches. Omega-3 fatty acid supplementation for headaches and cognitive function. There was a big study in the military, but it didn't really bear out the way we would have liked it to, because it would be nice to be able to just give kids omega-3 fatty acids and sort of feel better about that. But it doesn't really seem to help after the fact. There's maybe some very limited evidence that suggests that if you pre-treat all these kids, maybe there's, right, they have a little bit more resiliency in terms of recovery, but after the fact doesn't seem to do too much. With regards to current and future research, just briefly, advanced neuroimaging, that's what we use in our studies to sort of tell us about cerebral blood flow and things like that. Obviously, we don't have a functional MRI machine at Bayfront, and I'm sure you all don't have that at your institution, so it's not there yet, but it's something to think about in the future. Because these identify areas of the brain that have altered structure and function that correlates with our post-concussive symptoms. So in terms of our vestibular realms of function and our oculomotor realms of function, we see that they're getting decreased blood flow and have increased metabolic demands. There's also some patient body fluid assessment. So, that's sort of truthfully what we're looking to see. Would there be a really simple blood test or saliva test to help us understand if there are any evidence of brain injury? And we're looking at some of these biomarkers. They're not quite ready for prime time. There's also some genetic markers, and that's in fact what our colleagues over at All Children's are looking at right now, that seem to confer an increased risk for both development and concussion, and also increased severity of symptoms and prolonged symptoms after concussion. So that apolipoprotein E4, which we know about in Alzheimer's research, also seems to confer an increased risk for developing concussions and for developing prolonged symptoms after concussion. So those might be there sort of in the future. Let's talk briefly about prevention. Because that's our goal, truthfully, is to try to prevent these athletes from having concussion in the first place. We want them to go out, play their sport safely, and then be able to do whatever they're going to do for the rest of their life also safely. I mean, that's what I always tell these athletes is, especially in high school, they're so focused on going back to the field on Friday or being able to go to college and play at the next level. But I tell them, you know, you need your brain for the rest of your life. And so that's really our number one goal, is to protect this, and that's where prevention comes in. Rules changes have made a huge difference in terms of preventing concussion. So a lot of changes in the helmet-to-helmet rule changes, kickoff rules, targeting with the crown of the helmet and the strike zone. In youth, really, it's about educating coaches and parents to be much more cognizant of the symptoms of concussion. So we want to change the culture also. Certainly, I'm sure we all remember coaches of yore who would say, shake it off and get back in there. And now really the attitude is, when in doubt, sit it out. And so our coaches understand that, our athletic trainers understand that, our parents understand that, everyone's on the same page. Making sure that we understand the difference between pain and injury. You know, if they used to say, like, they got their bell rung and then they just go back in there and play again, we don't encourage that anymore, and that's probably suggestive of concussion. Seeing stars, getting dung, we don't recommend any of those things. We also don't encourage blindside hit drills. So going back to that picture I showed you where everybody's eyes are closed, or that culture of sort of getting the quarterback when they're not paying attention, we know that if the neck muscles aren't appropriately stabilizing the cervical spine and the head, there's an increased risk of developing concussion, because there's just a much larger accelerational force following that hit. And so it's about making sure that athletes on both sides, both the ones giving the hit and the ones sustaining the hit, are prepared for it. And that's where a lot of these rule changes come in. So that helmet down instead of the helmet up, that prevents that receiver from being blindsided. And we also want to teach them how to take and deliver a blow appropriately, and also how to head the ball appropriately, how to avoid contact with the ground or the equipment when they can help it. So it all goes back to coaching and parents. We also have some new guidelines. So Pop Warner, the sort of Little League football, they've limited the number of contact practices. There's been some controversy recently as they've talked about limiting contact practices in high schools and in colleges across the country. You know, we could probably debate whether or not that's appropriate. You know, on the one side of things, you want to encourage these athletes to learn how to take and deliver the blows appropriately. You know, if we avoid, most of our concussions occur in games, they don't occur in practice. And so limiting the number of contact practices probably wouldn't significantly decrease the number of concussions that are sustained. What we want to do is teach them how to deliver those blows where you are going to sustain contact with your head or another part of your body or with somebody else's head. We want to teach them how to do that safely. And I think that that's probably the more correct thing to do. You know, in a 5-year-old or a 6-year-old, probably if they're not doing contact 3 days of the week, it's okay. But in our high school and our collegiate athletes, where there's much more mass and they're going to be hit pretty hard on Saturday or Sunday when they're playing, we want to make sure that they can do that safely. And so I don't know that limiting contact practices during the week is going to allow them to do that. There's been a lot of time, you know, we used to see all of these, especially girls soccer players, come in with these headbands that they were told would decrease their rates of concussion. So nothing, there are no mouth guards, there are no helmets, there are no neck collars, there are no headbands that prevent concussions. They are important in terms of protecting against skull fractures, dental injuries, cervical spine injuries. So if your sport requires you to wear one of those things, you should do it just to protect against those other things. But there's nothing that we know of right now that will protect against concussions, because like I said before, the risk to each athlete is so individual. There's not one sort of blanket thing that we can do to just obviate that risk of concussion. So most importantly is education. For athletes and coaches to recognize signs and symptoms, to avoid unsafe teaching practices, and to understand the need for cognitive and physical rest following a concussive injury. The other important thing that we can do as physicians is our pre-season evaluation. So when we're seeing these athletes, we want to ask them about previous histories of concussions, because we know that it increases their risk of future concussions. Any athletes with a history of concussion, we want to know how many concussions did you have over how many seasons, what symptoms were you reporting, and how long did it take you to recover. If you're noticing a concerning pattern where they've had, 5 concussions in the last season, and in fact their last season ended prematurely because it was limited by concussion symptoms, and they're actually still reporting headaches, and then you go ahead and you do the physical exam and there's some balance deficits, that is not an athlete that should be cleared to go back to play. You also want to identify the type of sports that they're participating in. I mean, Some of our athletes might need to transition from football to something else, or from basketball or girls soccer to another sport, so that they can still play and be active and healthy, but not play in a sport that's increasing their risk of concussions. So actually my college roommate used to play at a Division I college in Maryland, field hockey, and she actually sustained so many concussions that she transferred to my school, which was Division III, and joined the cross-country team, where there is no risk of getting hit by anything. And she's very successful now, but she could not continue to play field hockey. And they sat down and they said, Cindy, I'm sorry, you just can't play field hockey anymore. You've had too many concussions and it's taking you too long to recover. So we don't like to have those conversations. I mean, it's the same as having that conversation with the athlete with, the athletic heart, sitting them down, or excuse me, the hokum, the pathologic heart, sitting them down and saying you can't play football anymore. It's tough to do it, but I mean, if it protects their brain, if it protects their heart, then we need to do that. Review the kind of protective equipment that they're using, and also review any previous face, head, or neck injuries, as that can sometimes either suggest unsafe practices or kind of suggest an increased risk of concussion, or perhaps an unreported concussion that they'd had in the past. When we talk about sequelae of concussions, this is the thing that we're all scared of, and this in truth is the reason why there is legislation surrounding concussions. There is a risk of chronic traumatic encephalopathy. This we've seen with recurrent concussions. Currently, there's no magic number to stay below and assure safety, and that's why it's really an individualized approach. And it's associated with a range of symptoms that are similar to a post-concussion syndrome. So depression, anxiety, decreased cognitive function, headaches, balance defects. And that's where all of the studies that are going on now with the NFL Brain Bank are sort of targeted towards all of those very high-profile athletes coming out of the NFL who had sustained multiple concussions, who then died in various ways, either by suicide or in sort of violent ends. Even Alex Hernandez, the one who, right, he hung himself. So they think that Alex Hernandez from the Patriots, that's right, thank you, who, he killed his girlfriends. What did he do?
He killed a guy that was hitting on him.
Right, exactly. So that was sort of out of character, and then he hung himself, and so there are questions that maybe he also suffered some CTE. That's impossible to diagnose before death, and so that's where this NFL Brain Bank up in Boston is sort of doing a lot of this research, and that's where this huge lawsuit that's kind of currently underway with the NFL is looking at is there this increased risk of concussions that they didn't appropriately educate the athletes about, and then allowed them to return to play too soon. So that's one risk, that's a longer term risk. The other risk, the more immediate risk, is the risk of second impact syndrome. So second impact syndrome, there's this rapid cerebral edema which occurs as a result of a second impact while the player is still recovering from the initial concussion. And so that's in that first 7 to 14 days. If they're still symptomatic, we know that there's some altered cerebral blood flow and altered homeostasis in the brain. It can occur with any degree of concussion and any degree of impact. The brain just loses its ability to auto-regulate completely. And that results in edema, increased glucose metabolic rate, decreased cerebral blood flow, vascular congestion, herniation, coma, and death. It's very rare. We've only ever seen it in case reports, and I think there's something like 24 case reports since it was first reported from 1978, all in college athletes or younger. And again, like I said, even with prompt identification, mortality rate approaches 50%, and it's incredibly difficult to treat. So even if we identify it appropriately, we send them to the ICU, there's not a whole lot that we can do. So this in truth is what we want to prevent, and this is why we'd much rather be conservative and take them out of the game if it looks like they've sustained a concussion, to prevent that risk, in the immediate time period, and also prevent them from returning to any sort of contact play until they're symptom-free. Here are some of the long-term lasting effects of recurrent concussions: chronic headaches, cognitive and memory problems, inability to function and participate in their sports, depression, irritability, potentially some permanent brain changes, and potentially an increased suicide risk. So the American Association of Neurology has come out with some recommendations for when we recommend that athletes retire from contact play. Athletes with history of multiple concussions and subjective persistent impairment should be counseled about the risk of developing permanent and long-lasting cognitive and neurobehavioral problems. Athletes with increased length of symptoms, concussions from minimal trauma, or decreased time between concussions, we should discuss maybe retirement from play. And we should counsel those with objective evidence of chronic persistent neurologic or cognitive defects on retirement from contact sports. Because again, we want to preserve this brain as much as we can. We only get one. So in conclusion, concussion is a complex neurobiological process resulting in an array of clinical problems. If the concussion is suspected, the player should be immediately removed from play and undergo a validated sideline assessment. Most concussions are self-limited and symptoms are transient, which require no treatment aside from rest. For a minority, these symptoms will persist and develop into post-concussion syndrome. And there is some research and new treatments that we're continuing to sort of undergo and develop to help guide these return to play decisions. And I have my questions at the end. So neuropsychological testing are objective measurements of several cognitive domains which can be affected following a concussion and can be a more sensitive marker of recovery versus symptoms in the clinical exam. Although the types of testing vary and can include paper and pencil or computerized testing, all testing should assess all of the following with the exception of A, reaction time, B, attention span, C, visual recognition and memory, D, processing speed, E, oculomotor reaction. And the hint is that one of these is a physical exam test. So that one probably is not assessed on paper and pencil or computerized testing. So E, right? So ocular and motor reaction time, that's that convergence test that's very easy to do in the office, or rapid alternating eye movements back and forth this way or this way. That we do in on our physical exam, and then we can treat it with physical therapy and vestibular therapy. Which of the following factors may affect recovery course after a concussion? Age, gender, prior concussion, history of headaches, or all of the above? As one of our colleagues who teaches test taking tells us, if you recognize more than two is right, then the answer is always all of the above, right? So E, all of the above. Female gender, history of headaches, younger age, and prior concussions all portend a more protracted recovery, unfortunately. Also, symptoms of migraine headaches, fogginess, or dizziness are associated with a prolonged recovery. Question 3, which of the following protective devices have been associated with a decreased risk of concussion when used properly? A, helmets, B, headbands, C, no protective devices, D, mouth guards, E, cervical collars. So C, right? The correct answer, the other thing is that Dr. Brown always says that if somebody wrote a really long answer and everything else is really short, the really long answer is probably right, because why did you spend that much time writing a wrong answer? This is just our test taken. We'll do that one too. The correct answer is C. So unfortunately, despite marketing claims, no protective gear currently available has been found to decrease the risk of concussions. All right. When can an athlete safely return to competition following the diagnosis of concussion? Once they are asymptomatic, if this occurs during the same game as the initial injury, they can return and complete the game. We know that's not right. When they're asymptomatic, in school or work full-time without accommodations, have completed an appropriate return-to-play protocol under the guidance of their coach and trainer, as well as a healthcare professional. That sounds pretty good. When they're asymptomatic, neurocognitive testing is at baseline and have completed an appropriate return-to-play under the guidance of their coach and trainer, as well as a healthcare professional. I don't remember mentioning neurocognitive testing in any of my guidelines before, right? And not everyone has access to it. When they've been cleared by their physician to return to sports, that doesn't sound right, that hasn't been long enough. When they're asymptomatic and back in school and work full-time without accommodations. That also doesn't sound right, right? So B, when they're asymptomatic, back in school, work full-time without accommodations, and have completed an appropriate return-to-play protocol under the guidance of their coach and trainer, as well as the healthcare professionals. And remember that any school-age athlete should not be allowed to start a return-to-play protocol until they're back at school full-time without academic accommodations. What percentage of patients will report continued symptoms past the expected healing time course of 7 to 10 days? 30%, 5%, 15%, 25%, 50%. 15%, right? So 10 to 15% will continue to report symptoms past 7 to 10 days following the initial injury, and they may require more intensive and multidisciplinary care for adequate recovery, and that's where vestibular rehab, neuropsychological evaluation, medications might be considered. And that's it. I have some selected sources, but if there are any questions, I'll be happy to take them. Thank you.
Any questions?
Questions?
Well,
Of course, I have a question.
During emergency medicine, I could listen to you guys talk all day, but some question I have that might be of interest to the group is, my observation is there's a increased risk of concussion in high temperature conditions. And patients or athletes who are working in either hot weather down here in Florida, which is 9 months of the year, or back in the Midwest in the summer, I'd often see an athlete who would sustain what was relatively a minor, or appeared to be a minor head injury, and they definitely had prolonged concussive symptoms, would even seize. And I wonder if there's any studies out there about an association between dehydration. I don't really think it's the temperature. I think it's the dehydration and concussion.
That's
Dehydration and hydration status.
certainly, I don't think there are any large-scale studies looking at that specifically. I think a couple of things. The first is that when we're talking about summer practices, that's usually when they're just getting back into play.
So they're less
and so they're less conditioned. Those cervical neck muscles are not as strong as they would be later in the season. And they might be utilizing some unsafe practices that might predispose or increase their risk of developing concussion. That's one thing. The second thing is that dehydration in and of itself probably also goes into that autoregulation and that decreased cerebral blood flow and that lactic acid formation. And so it would be worth looking at. I mean, dehydration contributes to all sorts of things, but I would suspect that it's probably a combination of things, because we definitely see more concussions, you're right, in those summer months, but for us it's really more, it's a deconditioning thing.
Yeah, well, theoretically, we think of if you have a dehydrated brain, so basically a smaller brain sitting inside the box,
Right.
more chance of you getting concussed. While theoretically it makes sense, there's nothing that has been proven clinically to be the case.
Okay. I would be interested if that would happen. And Dr. Karju had a very interesting observation.
Oh, no, so we were just chatting offline that, I see a lot, as a gastroenterologist, I see a lot of these patients come and they have issues with dysphagia or nausea, chronic nausea, or IBS that lasts a whole year or more. And there really isn't a lot of good treatment for it. I had a patient who was a cheerleader and had a pretty bad concussion and essentially developed nausea with smelling food, eating, like looking at food, she told me I couldn't even watch the Food Network. So it's interesting that there's sensory, it's almost like a sensory overload, and on the GI medicines really don't really address that.
I think that really there's probably a lot of overlap between the female gender. Again, you saw that history of patients with anxiety, depression. Probably there's this increased sort of somatic state that's like that heightened anxiety state that we see in the IBS and in all those patients that then will have those more protracted symptoms and maybe some of those other somatic symptoms that can be challenging. And that's where some of the interdisciplinary medicines that we use for IBS, like an SSRI or a TCA, might be reasonable to try, and some of those patients are not, like just your Zofran or things like that. Yes, Dr. Powell.
Is this protocol used in college as well?
That graded return to play is used in colleges as well. So we use it as our guide for any athlete that's coming in our door. The form that I showed you is for Florida high school. So if a middle schooler sustains a concussion, technically it doesn't count. If they sustain a concussion on, outside of outside of high school sports, so a travel team or something like that, it technically doesn't count. We'll still use that in every in Eckerd College, for example, where we also cover, and at USF where we cover, we will use that same graded return to play. So
The graded return to play, it's a recommendation first of the Zurich International Consensus for Concussion in Sports, and now the Berlin update.
Right.
So it's a standard recommendation from the International Consensus for Concussion in Sports regarding this should be the graded return to play.
Right.
So most of these guidelines that the states have developed are following those recommendations from that.
Thank you for the overview. It was very good. As a pediatric endocrinologist, we take note of the potential for pituitary injuries, and certainly in our literature, we report maybe as much as 30% of children with concussive events can have some sense of growth hormone deficiency. I want to pay attention for adrenal deficiencies of subtle nature and thyroid. So if they're in the growth phase, pay attention to their growth profiles. Also, we think that maybe 6 to 12 month follow-up assessments, particularly with attention to the growth as well as perhaps hormonal levels themselves.